I'm going to go ahead and start. I'm Sally Powers, Director of the Center for Research on Families. I want to let you know our time schedule. We usually go about a quarter past the hour, so we have enough time for questions and answers. And we are delighted to have everybody here today. This is our last in the spring series for the Tay Gavin Erickson Lecture series of the center. We're thrilled, as always, to have Gavin here and friends, as well as everyone else. The purpose of the lecture series is not only to bring really the experts in different areas here to give public lectures that we can all enjoy, but we also have a secret mission with these lectures, and that is that the expert spends some time really giving very thoughtful mentorship or consultation to our family research scholars, which are a select group of faculty who work through the center for a year on major grant proposals focused on their own research area. And the person family research scholar who is benefiting from this particular expert today is Becky Spencer, who is an assistant professor in psychology. And Dr. Spencer studies sleep and its influences on cognitive development throughout the lifespan, all the way from looking at the effects of preschool naps on learning to sleep with the elderly. So Becky is going to introduce the speaker.
Yes, and I'm thrilled to welcome Dr. Sonia Ancoli-Israel to today, and she's professor of psychiatry at UC San Diego, and she is the author of over 300 publications, which is always impressive to take account, and which have collectively documented the impact of sleep and sleep disorders in an array of populations, including individuals with Parkinson's disease, individuals with breast cancer, caregivers, as well as individuals with primary sleep disorders. And her work has really inspired my work for many years, and it has been a privilege to have her here today and get to know her more and have her not only influence just our work and our research strategy, but also my grantsmanship. And that's been truly a pleasure, for which I'd like to thank the Center for Research on Families, as well as the Gavin family, and not just for today, but also this full year. That's been a great experience. And thank you, Dr. Ancoli-Israel, for coming today and for your talk on sleep and sleep disorders in older adults.
Which I think may be a different title than what you had, but the talk's the same. Thank you. And thank you so much for inviting me. I want to thank the center. No, they actually want it left on because they're using it for the video. I want to thank the center for inviting me. I want to thank Gavin for sponsoring this Tay Gavin Erickson lecture series, and I'm honored to be one of the speakers in this series. And thank you also to Sally Powers for the invitation, to Becky Spencer for suggesting that I come here, and to Wendy for making all the arrangements and getting me here so easily. So thank you, all of you. As you heard, I've been studying sleep and sleep disorders in elderly for a very long time. And it's really an exciting area because we're all getting older and we want to keep getting older. So we want to do it in a way where we understand the things that happen to us. I should start off by saying that if you fall asleep while I'm speaking, I never take it personally. I know it means you have a sleep problem and has nothing to do with what will be a very entertaining talk. So. Having said that, I'll start with this. I always start with this cartoon when I speak on aging, so let me read it to you. This is Marvin. Marvin's playing a game with his grandfather, and he thinks, Grandpa fell asleep playing with me. I better put these someplace for safekeeping, and he takes Grandpa's glasses. And of course, it's not the glasses I care about. It's the fact that Grandpa fell asleep while playing a game. And people think this is funny, thus the cartoon, when in fact, it's not. There is never an appropriate time to be falling asleep like this. The fact that Grandpa fell asleep means that there's something wrong with Grandpa's sleep. Just because he's older doesn't mean he should be falling asleep while playing a game. And if nothing else, you should remember this. This is never appropriate behavior, no matter the age of the individual. So the question is, why do these things happen? So first of all, we should look at what we know. And I will get to the dementia part of this. But to understand sleep and dementia, you first have to understand sleep and aging, since the majority of demented patients are in fact older. So we're going to start with talking about sleep and aging and work our way into dementia. So there's been this myth out there that as we get older, we need less sleep. But in fact, if you look at data, you find that older adults really don't sleep the amount of sleep they get is really not that different than younger adults. So these are data from the National Sleep Foundation, which is a nonprofit organization whose mission it is to educate the public about sleep. And every year they do a survey related to sleep, and in 2003, the survey was in older adults. And what we're looking at here are the data from the older adults, which unfortunately they define starting at age 55. Some of us disagree with that definition, and we're comparing it to data from previous surveys. So the blue is the younger, the 18 to 54, the purple is 55 to 64, the yellow 65 to 84, and the orange is the combination of the so-called older group. And what you see is that during the week, older adults are reporting sleeping about 7 hours, younger adults are 6.7. So if anything, the older adults are sleeping more than the younger adults, not less. On weekends, the younger adults are sleeping 7.5 hours, and that's because they're making up for their sleep deprivation here. 6.5 hours is just not enough sleep. But you see the older adults are maintaining at 7 hours. So the fact that, that older adults need less sleep is probably, in fact, a myth, probably not true. When we look at studies, though, that have been done at what happens to sleep as we get older, it's clear that sleep does change. There was a wonderful meta-analysis of over 3,500 adults from age 5 to age 102. And what they found is that most of the sleep-related changes are not just occurring in the older age groups. It's actually starting younger. In fact, at around age 30, you start seeing changes in the sleep architecture, particularly the amount of deep sleep that we see. But once that healthy older adults hit age 60, it actually remains rather constant, except for sleep efficiency, which I'll define for you in a minute. But so this is the slow wave sleep, and this is our very deepest level of sleep, and you can see that already at around the mid-20s, early 30s, it's already begun to decrease. It continues to decrease. This is age 36 to 50, and then it actually remains rather stable. So I'd say, looking around the room, for most of us, not all of you, but for most of us, we've already begun losing much of our deep sleep. Sleep efficiency, on the other hand, does decrease with age. So sleep efficiency is defined as the amount of sleep given the amount of time that you're in bed. So in the ideal world, that would be 100%, right? You'd be asleep the whole time you're in bed. But obviously, it takes everyone at least a few minutes to fall asleep. Everybody wakes up once or twice during the night. So we consider a sleep efficiency of 90% or above to be good sleep efficiency. And what you see here is that with age in both men and women, sleep efficiency does begin to drop. And the question is why? What is happening? If it's not the sleep architecture, and if it's not the fact that older adults need less sleep, why is sleep efficiency dropping? And we will attempt to answer that for you in a minute. But first, I want to talk a little bit about what are the consequences of poor sleep in older adults. There have been two very large studies. One is called SOF, or the study of osteoporotic fractures in women. The other is the Mr. Oz study, which is a similar study in men. Both of these started out looking at osteoporosis. They have since evolved into many other things, one of which is sleep. And there are thousands, you can see over 3,000 just in the sleep part, but there are over 10,000 men and 10,000 women that have participated in these studies. And we've had the opportunity to study sleep, and we have measurements on everything you can possibly imagine, so we can look at associations, predictors of poor sleep, etc. So in this slide, we're looking at the relationship between sleep disturbance and depression, and what we know is that So let me back up a minute. Everybody sort of believes and knows that depression is associated with poor sleep. What we're now learning is that poor sleep is also associated with depression, to the effect that if you have poor sleep, it puts you at greater risk for a first episode of depression. So it's not always the depression leading to poor sleep. The arrow actually goes in both directions. So in the older studies, what we found are those people that had poor sleep quality or took more than an hour to fall asleep were actually at greater risk both for depressive symptoms and for outright major depression. Similarly, if you look at physical function, and here we define physical function as the ability to get up out of a chair or to walk down a narrow path, and what we found is that low sleep efficiency here was below 80%, or being awake more than 90 minutes during the night also put you at greater risk for poor physical function. So there are clearly consequences in the older adult to not sleeping well. What about cognition? Same thing is true in cognition. Sleep efficiency less than 70%, taking 30 minutes or more to fall asleep, or being awake during the night for 30 minutes or more put people at greater risk for more cognitive impairment. And we actually have studies now as well showing that those people who have poor cognitive function are also at greater risk for developing worse sleep later on. And of course, when we get to the dementia part, we'll talk much more about cognition. What's even more relevant or more important is that the poor sleep was also associated with increased risk of falls and increased risk of mortality. And in all of these studies, I should point out, this is after controlling and adjusting for everything possible that we should adjust for. So not only race and age and body mass index, but medications and all the medical and psychiatric illnesses. So all of these have controlled for that. So in terms of falls, there was a 30 to 40% increased risk of falling for those sleeping less than 7 hours a night, or sleep efficiency less than 65%, and the increased mortality risk for sleeping less than 5 hours, sleep efficiency less than 65, or taking a very long nap during the day. So poor sleep can have some very serious consequences, from mood to physical function to death in the older adults. So it's important to understand why these older adults don't get good sleep, and then of course what we should be doing about it. So the consequences in general, the problems with memory, problems with concentration, all these things are also associated with poor sleep. Response time. And I like to point out that when we talk about slowed response time, we're not talking about how long does it take someone to push a button in response to a stimulus. We're talking about how long does it take that older person to slam on the brakes when a child is running in front of the car chasing a ball. That's the problem with a slower response time. And we see these consequences in everybody with insomnia or sleep deprivation, poor sleep. But the problem with the older adult is these can be misinterpreted as dementia. So the older patient goes in to see their doctor and says, you know, I'm a little slower than I used to be, or I'm having a little trouble with memory. And the first thing that doctor's going to think about is, dementia. But in fact, it might be insufficient or disturbed sleep that's causing some of these symptoms, and not dementia per se. Now, having said all that, the prevalence of insomnia in the older adult is actually quite high, and quite a bit higher than in the younger adult, depending on which study you look at. About 50%, if not more, of older adults do have insomnia, and I should define insomnia is defined as difficulty falling asleep, difficulty staying asleep, or non-restorative sleep, which results in some daytime dysfunction. So it's not just not sleeping at night. That not sleeping at night has to affect your ability to function during the day. But what you can see here is that in general, chronic sleep disturbances are in the older adult are primarily associated with some comorbidity, some medical or psychiatric disorder, the medications that the person is taking, or primary sleep disorders. So if you look at very healthy older adults, you find in fact they have very little complaint about their sleep. And in this follow-up study to the data I just showed you that Foley and his colleagues did, what he found was at a one-year follow-up, 50% of the patients that had insomnia when they were first studied no longer had insomnia. And those that no longer had insomnia improved in those patients, their health improved. So insomnia is very closely tied to poor health. And in fact, Foley concluded, and I love this quote, "These data do not support a model of incident insomnia caused by the aging process per se. Aging alone," I think I have this on the next slide, "aging alone," this cartoon says, "hospital admissions, register here. Age?" And he says, "I sure do. Aging alone doesn't cause sleep problems. It's all the other things that happen to us as we get older that result in poor sleep." So as I said, very healthy older adults don't have the sleep problems. It's the ones that have the other comorbidities. And so in fact, those are the factors that lead to poor sleep. The medical illnesses, all the medications that we give patients because of their medical illnesses, changes in their biological clock, their circadian rhythms, and then the high prevalence of primary sleep disorders. And what I'm going to do for the next few minutes is touch on each of these to show you how these affect sleep in the older adult. So if we start with medical conditions, pretty much any medical condition that causes discomfort is going to be associated with poor sleep at night. Whether it's the neurological disorders, whether the pain of arthritis, whether it's cardiac disease, they all are associated with poor sleep. And I want you to notice that I use the word associated. I am not using the word cause. Because we used to talk about insomnia as being primary or secondary to medical illnesses, etc. And in 2005, the NIH held a large consensus conference on insomnia and really took a 180-degree turn on how we define this disorder. And we now talk about it being comorbid with these conditions. And this has serious implications for treatment. Because if something is secondary, you treat the primary problem, right? So if the insomnia is secondary to pain, you would treat the pain, and the insomnia should get better. That doesn't happen. What we find is you have to treat these conditions concurrently. They are comorbid. And when you treat them together, you get a much better response. There's a very elegant study that was done looking at patients with depression and insomnia. Half of them were treated with an antidepressant and a sleeping pill. The other half were treated with an antidepressant and a placebo. And what they found was that those that got both the antidepressant and the sleeping pill did better, not just on sleep, which you would expect, but they actually did better in depression as well. So it's very important when people have insomnia and some other medical or psychiatric condition that they be treated concurrently, because they're associated, but they're not necessarily causal. The more medical problems a person has, especially older adults, the worse the sleep gets. So again, these are data from that survey in older adults that the National Sleep Foundation did. Here we have reports of sleeping less than 6 hours a night, any insomnia, or being excessively sleepy during the day. And our colors here are no medical disorders is the blue, having just one is the pink, the yellow is 2 or 3 medical disorders, and the orange is 4 or more. And you can see, especially for insomnia, but the more medical conditions the person has, the worse the sleep was. I want to let's go back to the sleeping less than 6 hours. I'd like to see a show of hands. How many people here got 7 to 8, let's say more. How many people got more than 8 hours sleep last night? Wow, 4 people, that's a lot. Good. 7 to 8? Nice. Oh, there's something very special about you that live here. So I say 6 to 7? Okay, and less than 6? Not many. Usually it's skewed the other way. Usually it's most people are sleeping less than 6. That is a very nice distribution. Okay, because you see, if you sleep less than 6, you have many more problems. You'll see that over and over again. Okay, so we talked about the medical and psychiatric illnesses. What about medication? So here's Marvin again. He's sitting with his little cousin, and he says, "How come Grandpa never goes to a job like other big people?" "Because he works at home, silly. See, he runs a drugstore." Well, clearly, we see a lot of polypharmacy in our older adults. They have a lot of medical conditions, and so they get a lot of medications, sometimes more than they need. But all that polypharmacy, all those medications, are also associated with poor sleep. And to simplify it, a medication is either activating or sedating. And when you take a sedating medication during the day, it makes you sleepy, which could interfere with your sleep at night. If you take an activating medication at night, it's going to interfere with your sleep at night. And so sometimes by just changing the dose or the time of day that someone takes their medication, we can have a tremendous positive impact on their sleep. I also want to point out that in addition to all the prescription medications, I also have alcohol, caffeine, and nicotine here. A lot of patients, a lot of older adults, not even necessarily patients, will use alcohol to help them sleep. You know, the glass of wine or sherry before bedtime. And alcohol does make you sleepy initially, but several hours later when the alcohol leaves your bloodstream, it wakes you right back up again. Alcohol causes insomnia. Or you look at the person who has several drinks with dinner, they might be sleepy initially right after dinner, but several hours later, when the alcohol leaves their bloodstream, when it's time to go to bed, they're wide awake. So they may come in complaining of difficulty falling asleep, and it might be related to how much alcohol they had with dinner. So it's very important to think about that. Caffeine, you all know about caffeine, and now we have to talk not just about coffee and tea, but Red Bull and all the other energy drinks that people are drinking. And I don't know if they've done this yet, but I've been seeing lots of articles about certain companies combining beer and caffeine, so you can get all at once, your alcohol and your caffeine. God knows what that's going to do to people's sleep. But even if you think that you can have a double shot of espresso right before bedtime and it won't affect your sleep, if I record your sleep, I would show you, in fact, it does. So caffeine is a major problem. And nicotine, in case people don't have enough reasons to stop smoking, there's one more. So drugs, whether prescription, over-the-counter, or things like alcohol and caffeine, certainly play a role in disturbed sleep. And in the elderly, that's a particular serious problem because of all the medications they're taking. Okay, what about circadian rhythms, our biological clock? So I love this picture. I cut this out of a magazine. I can't even remember what it was an ad for. But if this isn't exactly what happens to the older adult, you know, they go to the opera, they go to the symphony, and they fall asleep, and I'll explain why in a minute. But Benjamin Franklin was wise enough to say early to bed, early to rise, and then, of course, it continued, makes a man healthy, wealthy, and wise. I don't know about that part. But the early to bed, early to rise describes what happens to older adults as our rhythms change. So let's talk for a minute about circadian rhythms. So circadian rhythms are our biological clock, our internal biological clock. Circadian, the word circadian is from the Greek. It means about a day. And it really is about, because if you look at the actual timing of our circadian clock, it's not 24 hours, it's a little longer. And that's why every morning when the sun comes up, hopefully you actually see the sun, the internal clock gets reset by that light. So for most people, the pattern of wake-sleep is that most adults get sleepy around 10 or 11 o'clock. Part of what controls that is our core body temperature. Core body temperature drops at night. That's when we get sleepy. It rises in the morning hours, and that's when we get up. And most adults need 7 to 8 hours of sleep. And again, I'm so glad to see that many of you are doing that. But different times in our life, this pattern changes. So how many of you have teenagers? How many of you used to be teenagers? So you might remember not wanting to go to bed till 1, 2 in the morning, sleeping till noon, and then as parents we yell at our kids and say, you know, you're sleeping the whole day away, stop being so lazy. Well, it turns out that that pattern is very common in adolescents and young adults. We call this a delayed sleep phase. Their core body temperature isn't dropping till maybe 1, 2 in the morning. And that's when they get sleepy. So if they try going to bed at 10 or 11, they tell you they have insomnia. They have a hard time falling asleep. It takes them hours. And indeed it does, because their body is just not ready. And adolescents need 9 to 10 hours of sleep, much more than adults. And so in fact, if they're not falling asleep till 1, 2 in the morning, they're going to sleep till 10, 11, 12. Very normal. The problem is, of course, that high schools are starting at 7:30 in the morning. So for them to sit in a math class at 7:30 in the morning is like the rest of us trying to sit in a math class at 3 in the morning. Very difficult, which is why most high school students fall asleep in their first period classes. That's been shown over and over again. So most adolescents will outgrow this. As they grow into adulthood, the pattern does shift some more or advance back to this state. I should point out that some people stay delayed their whole lives. We now know that there's a genetic component to that. And those are our night owls, right? The night people. They like working nights. Their best time of day is late in the afternoon, the evening, because of that circadian pattern. So for those that do go back, as we continue to get older, and we're getting back to our older people now, this pattern continues to advance so that older adults have what we call advanced sleep phase. Core body temperature with age also advances, so it's dropping earlier in the evening, maybe 6, 7, 8 o'clock in the evening. Right? And if the older adult went to bed at 6, 7, 8 o'clock, they'd have no trouble falling asleep. They would sleep their 7 to 8 hours, but if you do the math, that means they're now waking up at what, 3, 4, 5 in the morning. What is the biggest complaint that most older adults have? I'm waking up in the middle of the night, here it is, the middle of the night, and I can't get back to sleep. And they can't get back to sleep because physiologically speaking, their night is done. It doesn't matter that the sun hasn't come up yet. Okay? Core body temperature is rising, and they're finished sleeping. Problem is everyone else in the house or around them is still sleeping, and they're not. And so that's why they complain. Now, two things happen. One is, even though they might get sleepy at 7 or 8, they don't go to sleep at that hour. They want to have a life, and everyone else is staying up, so they sort of force themselves to stay awake. They go to sleep later, but they're still waking up at 3, 4 in the morning. Now they're not in bed long enough to get a full night's sleep. You can't sleep 7 to 8 hours if you're only in bed for 5, right? So they're tired during the day. They might take an afternoon nap, and that nap allows them to stay alert later into the evening, but they still wake up at 3 in the morning. So now they're in this cycle of not getting enough sleep at night and needing to nap during the day. Second scenario, they come home, they have dinner. After dinner, they sit down to read or watch TV, and what happens? They fall asleep. And they sleep maybe for half an hour, maybe an hour, over their book or in front of the TV. And by the way, if you ask them, do you nap? They go, oh, no, because it turns out that sleeping in front of the TV doesn't count as a nap. I don't know if you knew that. So you have to be very careful how you ask the question. Okay, so they nap for a little while, then they get up, they get ready for bed, they get into bed, and now what happens? Wide awake, because they just slept for half an hour or more. So now they come in to see you and they say, gosh, I have trouble falling asleep when I go to bed at 10 or 11 o'clock, and I'm waking up at 3, 4 in the morning. I have horrible insomnia. But in fact, it's not insomnia. It's an advanced sleep phase in combination with some very bad habits. That is this napping in the early evening, which is disrupting their ability to fall asleep. And this is the most common thing that we see in our older adults, is this advanced sleep phase that people don't understand and most physicians know nothing about, so they can't identify it. And the reason it's important to identify is we treat circadian rhythm disorders such as this very differently than we do insomnia. And I won't go into the details here, but basically we use bright light, because light is the strongest cue our body has to know when to go to sleep and when to get up. And we can use the timing of light to help synchronize or shift rhythms. And that's why I said when the sun rises, it resynchronizes our circadian rhythms. So for the owl, night person pattern, we want morning light because that will advance the rhythm. For the older adult, we want evening light. That will delay the rhythm. And then you can either use the sun, or you can use light boxes. There are different approaches. And if there are questions about this, we can talk about this later. We actually use a combination and delayed of light and melatonin, but I won't go into that unless there are questions about this later. So advanced sleep phase, very common in the older adult. Okay, the other thing, in addition to the medical psychiatric problems, the medication use, the circadian rhythm disorders, are the high prevalence of very specific primary sleep disorders. There's one called restless legs and periodic limb movements, and I took those slides out because I thought I'd run out of time, but we can talk about those later too. But a more common one is sleep-disordered breathing, or sleep apnea. This is a condition where the airway collapses during sleep. So if this is the airway, right? Person falls asleep, the muscles of the airway collapse. In order to start breathing again, they have to wake up, and they wake up, the airway opens. They're trying to breathe, but the air just can't get in or out. And this can happen many hundreds of times during the night. We see people that stop breathing 30, 40, 50, 60 times an hour. Okay? So they're spending much of the night not breathing and not sleeping. And this disorder is quite common in the older adult. This is a photograph that I took when I was in Vienna. This is Brahms. I'm pretty sure Brahms had sleep apnea, because look at him. First of all, he's overweight. Sleep apnea is related to weight. He's older, you can tell because he has this white beard, and he's fast asleep. Who has a statue made of them fast asleep, right? So it must have been something he did a lot. So to me, he must have had sleep apnea. The other symptom that's very common in sleep apnea is snoring, and it's often very loud snoring. We ask our patients, how loud is your snoring? Can you be heard just in your bedroom? Can you be heard one room away? Are you a one-room snorer? Are you a two-room? Are you a three-room? Can your neighbors hear you? And often they will say yes, because that's how loudly they snore. Now, the problem with most older adults is that they often don't have a bed partner or someone else living in the house, so there's no one to help tell them if they snore or not. And snoring does increase with age anyway, even independent of sleep apnea. But if it's a very loud snore, it's usually indicative of sleep apnea. And by the way, women, we do snore. Not as prevalent as in men, but we do. As much as we deny it, we do it. And sleep apnea is also more prevalent in men, but we see it quite a bit in women. And in fact, postmenopausal goes up in women as well. So these are some of the prevalence data. So this is looking at how many people stop breathing at least 10 times per hour of sleep. Anything less than 5 is considered normal. 5, even 10 is considered mild, but in our studies we use that as a cutoff. And this is studies, these are data from what's called the Wisconsin cohort, which was younger adults, and you can see that the overall prevalence is about 10% in the younger adults, and in our studies of older adults it's about 62%. That means that more than 1 out of 2 older adults has sleep apnea. It's very, very common. And I could give you a whole hour talk just about what does that mean when it's so prevalent in the older adult. Is it different than the younger adult? And the bottom line is, if there are consequences with it, which there are, then it is a significant disorder that needs to be dealt with. And we're going to come back to sleep apnea because it plays also into dementia. One question is, why is it so much more common in the older adult? This is another very elegant study done in Harvard, where they did magnetic resonance imaging of the airway. And what they found in the older adult is that the whole airway is changing. So the soft palate gets longer, the pharyngeal fat pads get larger, the shape of the bony structures around the airway changes, and the response of the genuglossal muscle to negative pressure changes, and it's that negative pressure that causes the apnea. So all these things are probably contributing to the development or the increased prevalence, at least, of apnea in the older adult. So now we know that in general with aging, a lot of bad things happen to our sleep that are independent of age, but nevertheless are happening. So it's all those things we just talked about. So then the question is, what about in dementia? So the demented individual is going to have all those things we just talked about because they happen to be older, right? They're going to have additional medical and psychiatric conditions separate of the dementia. They're going to be on a lot of medications. They may be phase advanced. They may also have sleep apnea and restless legs. Let me just say quickly, restless legs is a condition where people have very uncomfortable sensations in their legs. They describe it as feeling like ants are crawling up and down the inside of their legs. And the only way to relieve that feeling is by movement. So they're shaking their legs or they're pacing. And I actually think that the pacing that we see in the demented individual may in fact be because of restless legs. The only way we can make the diagnosis of restless legs is by self-report, and you can't get self-report from that population. And so we don't know, and actually there are some people now who are finally starting to study that, but I think that may account for a lot of the pacing that we see in dementia. So the demented individual is going to have all these other things, plus the dementia itself is contributing to poor sleep. And we have done, as have others, lots of studies looking at sleep and dementia. And the way we do it is we use something called an actigraph. I'm assuming not everyone here knows what an actigraph is, so I'm going to explain it. An actigraph is a small device worn on the wrist that measures wrist movement. And from that movement, we can estimate if someone is awake or asleep. Basically, when we're awake, we tend to move. When we're asleep, we tend to be still. Not quite that simple, but almost. So what we're looking at here, this is called, well, first of all, this is a scale of activity. It's actually just an arbitrary scale, but the higher the line, the more movement there is. We're looking at what's called a double plot. So we're going from midnight to midnight of day 1, midnight to midnight of day 2. Day 2 is repeated down here. Then we have day 3, and then day 3 is repeated down here. And this is the end of that third night to the morning when the actigraph is removed. We also have the scoring of the sleep-wake. So when you see the very thick line, that's when we're estimating that the person was asleep. And when you see the very thin line, that's when they're awake. And basically you can tell. I mean, when you see a lot of movement, they're awake. And when you don't see much movement, they're asleep. So I have done probably over 1,000 recordings in older adults and demented older adults. This was one of our best ones. And what we see here is there are a couple of pretty good sleep outs. This is a great night's sleep. Any age, that'd be a great night's sleep. This third night, not as good as second night, but certainly better than the first, right? As I said, that was one of our best ones. What most of them looked like was this. And if I didn't have clock time down here, there would be no way to know what is night and what is day. And that's what happens with a demented older adult. They are constantly falling asleep and waking up and falling asleep and waking up. And this is going on all night and all day. And in fact, oh, I didn't put that slide in. Well, in fact, if you add up all those times of wake and sleep, what you find is on average, these patients are never asleep for a full hour and never awake for a full hour throughout the 24-hour day. Okay? Because it's constant. This falling asleep, waking up is constant. And the times of greatest alertness, I'm sorry, I didn't put that slide in. Times of greatest alertness, breakfast, lunch, and dinner. But even during those times, the patients were falling asleep part of the time. So, now the other thing that we found in this nursing home population is that sleep apnea was extremely prevalent, even more prevalent than in the non-demented older adult. So here you see, and this is, we did this so long ago that the equipment that we use is now totally obsolete. This was done in the 1980s. As I said, I've been doing this a long time. And this was one of our very gracious patients who agreed to let us take her picture. But what we found was 90% of the patients stopped breathing at least 5 times an hour. Although if you look at the mean, it was 32 times an hour. 63% stopped breathing 15 times or more an hour. This is not a night. This is an hour. And their mean was 40, and half of them had more than 20 events per hour with a mean of almost 47. So sleep apnea in dementia is quite common. And then the question becomes, what is the relationship then, actually let me wait, between apnea and dementia? Because think about it. First of all, we know in adults in the regular sleep clinic who come in with apnea, they complain or report problems with memory. They report problems with concentration. Imagine, if you're waking up 40 times an hour, and each time you're also not getting oxygen to your brain, that's going to affect a lot of things, including memory. And so we really became interested then in what the relationship is between apnea and dementia. And what we found was that there is a relationship. So on the top part here, we're looking at the dementia rating scale, where a lower score is more severe dementia. And we broke them out by how much apnea they had. So these are people that had mild to moderate or no sleep apnea, which we defined as stopping to breathe 20 times or less an hour, versus those that had severe, which was 20 times or more an hour. And you could see that those with the more severe apnea also had more severe dementia. And you can also look at the other way around. So if you break them down into mild, moderate, or no dementia versus severe dementia, those with severe dementia also had more severe sleep apnea. The correlation was low but significant at about 0.4. So there is clearly a relationship between sleep apnea and dementia. So the question then was, is it possible that the hypoxia and the sleep apnea, the hypoxia and the sleep fragmentation related to the sleep apnea might in fact be contributing to the dementia. So the question became, while we don't think sleep apnea necessarily causes dementia, is it possible that the apnea makes the symptoms of dementia worse? And if so, would treating the apnea improve daytime functioning and cognition in this population? And that led us into the study where, in fact, we took patients who were both demented and had sleep apnea, and we moved out of the nursing home this time. This time we were looking at community dwelling, older adults who had mild to moderate Alzheimer's disease, and we screened them for sleep apnea and then treated them. And we had a placebo group, so half of them were assigned to real apnea, real CPAP. Oh, I should tell you. So CPAP is, you've gotten my joke already. I'll come back to that. So this is CPAP. CPAP is a mask connected via hose to a machine which pushes positive pressure through the airway, which acts as a splint to keep the airway open during nights. Remember I told you in an apnea, the airway collapses. This is what keeps it open all night long so the person can continue breathing and doesn't have to wake up. So what we did is half of them were assigned to real CPAP, half of them were assigned to what we affectionately call the counterfeit respiratory assistance protocol, or CRF. And what we did is these masks had holes in them. There was a reductor in the hose, and it's amazing that the patients really did not know the difference because we checked later. And neither did their caregivers. As part of the inclusion criteria, they all had to have a caregiver living with them. So they were randomly assigned. And what we did, we ended up studying 52 patients. And half went into real, half went into the placebo. The real group had real CPAP for 6 weeks. The placebo group had the placebo for 3 weeks and then were switched to 3 weeks of real CPAP. So you can go from placebo to real. You can't really go from real to placebo. But in this way, we could compare the placebo to the real, and we can also compare 3 weeks to 6 weeks of treatment. And we tested them before they started treatment, at the end of the 3 weeks, the end of the 6 weeks. And they had, besides overnight sleep recordings, they had all sorts of questionnaires about daytime function, which the caregivers often helped them fill out because they couldn't always do it themselves. And the caregivers also filled out questionnaires about themselves. So we had information both about the patient being treated and the caregiver. And then we did a complete neuropsychological test battery at each of those time points because cognition was our main outcome measure. So the first question was, would these older demented adults tolerate CPAP? And the answer is yes. So here we have data. So the yellow are the people that used the CPAP for 6 weeks. The blue was those that had the sham or the placebo for 3 weeks, followed by real. So here's where they had the placebo, here's where they were switched to real. And you can see that basically on average, these patients use their CPAP for about 5 hours a night, which is as much, if not more, than many patients use it. Medicare, at least in California, I don't know if it's different here, requires at least 4 hours of use before they'll pay for a CPAP machine. So these patients were using it more than that. So the answer is yes, these patients will use CPAP and they will tolerate it. Interestingly enough, we found that depression played into the adherence. So those that used it less were also more depressed. So the more depressed they were, the harder time they had with it, which also has treatment implications. That, you know, if someone is depressed and we treat their depression, will they then adhere to their CPAP any better? So what else did we find? Well, first of all, we found that it did in fact improve the apnea. So again, this is the group that was on real CPAP for 6 weeks. This is the group that switched after 3 weeks. So you see that they started out pre-treatment at a high amount of apnea. It's about 30 times an hour. And as soon as they were treated, they went down to fairly normal levels. The placebo group stayed high. This difference is not significant, so they stayed high. But when they were switched to real, they also came down. So as you would expect, the CPAP was effective in treating their sleep apnea. It also changed or improved their sleep. Their sleep got deeper. So I told you about deep sleep. So stage 3, 4 is our deep sleep. Stage 1 is our very lightest level of sleep. That's the sleep where you're just dozing off and you're not completely awake anymore. That's the kind of sleep we do at the symphony, right, or the opera, the dark lecture halls, that intermediate sleep. And then stage 2 is a little deeper, 3 is the deepest. REM sleep is our dream sleep. So what you see here is they spent less time in the very light levels and more time in the slightly deeper levels of sleep. They also spent less time awake during the night. They woke up less often, and their oxygenation improved. So the CPAP actually deepened the sleep of these patients. This is a test of daytime sleepiness. It's something called the Epworth Sleepiness Scale, which asks questions about how likely are you to doze off at what we would consider inappropriate situations. So how likely are you to doze off in conversation, while sitting in a car, at a red light, or in a meeting, church, theater kind of thing. So it asks questions like that, and the patients rate themselves from 0 to no chance to 3, very high chance of dozing off. So a cutoff of 10 is considered inappropriately sleepy. And so the first thing I want to point out is that these patients never even reached 10. Even before treatment, they were only at about 8 to 9. I also want to point out that it's not the patients answering about themselves, it's the caregiver in most of the cases. So it's not, reporting about yourself is already not totally accurate. Having someone else report about you is even less accurate. Nevertheless, what we saw was that those on real CPAP did significantly improve after 3 weeks, and then it stayed stable. Those on the sham had no change until they were switched to real CPAP. So the CPAP, at least in the caregiver's perception, did improve daytime sleepiness. The most exciting part, however, was the improvement in cognition. What we found was that 3 weeks of therapeutic CPAP did improve cognitive functioning. We did not cure their Alzheimer's, okay? But what is happening, I think, is if the patient with Alzheimer's is starting at a certain level of cognitive impairment, and then you take their oxygen away at night and you wake them up hundreds of times during the night, that suppresses their baseline. And when you get them breathing and sleeping again, it brings them back up to their more normal level of cognitive functioning. So although we're not curing it, we did make a difference, and the caregivers noticed a difference in the cognitive ability of their spouses. So to summarize that part of it, patients with Alzheimer's disease do have a lot of sleep apnea. They will tolerate the CPAP, and they'll wear it as much as most clinic patients. The CPAP improved the apnea, the daytime sleepiness, nighttime sleep, and some aspects of cognitive function. And the caregivers, I didn't show you these data, but the caregivers also reported an improvement in their own sleep and their own quality of life. And as I said, the caregivers liked the fact that their spouses were using the CPAP so much that some of them asked that we prescribe it for them so they could continue using CPAP. And so it occurred to us we should do a follow-up study, which hadn't been in the original design. So what we did is about 6 months after the end of each person's study, we looked at 5 patients, small samples, 5 patients who continued using CPAP and 5 patients who did not continue using CPAP. And what we found is those that continued using the CPAP showed less cognitive deterioration, less depression, less daytime sleepiness, and better subjective sleep quality. And the caregivers also had continued to have improved sleep and rated their spouses as being more improved. So again, we didn't stop the progression of the dementia, but we seemed to slow down the deterioration. And if that's really true, if we could postpone institutionalization of these patients, not only would that save billions of dollars, but think about the improvement in quality of life for that person if they get to stay home. And I'll show you, I hid them. I didn't hide all of it. So just to show you, I think I just left one in here. So this is one of the tests we use for cognitive functioning. It's called the Stroop Color Word. It's a test of executive function. These are the 5 that continued using CPAP. These are the 5 that didn't. And you can see the score actually went up in those that up is better. So they showed improvement 6 months later whereas there's essentially no change or some deterioration in the group that didn't use the CPAP. So we need a lot more research in larger samples and good randomized trials to see if, in fact, this is true, that the continued use of CPAP slows down the deterioration, but it is very, very exciting. So the final conclusion is that the results of our study lend support to the hypothesis that apnea might be a reversible cause of cognitive loss, that treating it, particularly in the early stages of dementia, might slow down the progression, but we do need further studies to show if this is true. And with that, I just want to end with this quote. I like to always end with this. It's, aging seems to be the only available way to live a long life. So I hope we all continue to age gracefully, and to continue to get a good night's sleep along the way. And I'll just leave out my colleagues here. Thank you very much.